All right, in the interest of time, we're going to go ahead and get started. It's 4 minutes after. There seem to be a couple people kind of in the queue here. I don't know if there's some lag with the Zoom and the internet wherever they are. So hopefully they'll hop on here shortly. In the meantime, we'll go ahead and get started. We've got a didactic presentation as well as some cases baked in from Eric. So we'll be turning it over to him to present that. If at any time you have any problems as far as tech or anything, or have questions, go ahead and put those in the chat. I'll be monitoring that, especially while Eric's doing his presentation. So if you have any issues, just let me know. And I think we're ready to get started. So Eric, I'll turn it over to you so you can share screen and get started.
Sounds good. All right, let me get this to work. Okay, everybody see that?
Yep, sure can.
Okay, so I'm Eric Seacrest. I'm one of the MS doctors at WVU. And I have a very personal interest in MS as well, but we'll get into all that later. So we've already had a couple talks so far with this program. This is going to be focusing on how to make a diagnosis. I don't want it to be too technical, so I mean, if it's not getting across or questions about something, this is pretty informal, so just stop me, ask questions, that's totally fine. And probably about 15-20 minutes or so, we'll have some cases and then plenty of time for questions and some other things too. All right, let's go. All right, so we kind of talked about MS a few times already, but what is it? Just the basics. It's kind of the way we think about it for diagnosis. It's both an inflammatory disease, autoimmune, and also neurodegenerative. So we kind of have breakdown as well as inflammation. So two different things that we kind of go after with treatment. It's both a white matter disease and a gray matter disease. To kind of just historical context, it used to be thought only in the white matter, the brain and spinal cord. It turns out that's not true, which has expanded our treatments and been really helpful for us. And more things are coming. And then it is the most common non-traumatic cause of disability in young adults. So it has a massive impact on our population as well. All right, so how do we make a diagnosis? MS is similar to pretty much all neurologic disease, is that it's a clinical diagnosis. And what I mean by that is it's going to be seeing the patient, getting a history, getting an exam. Just from that visit, whether it be in the ER, in the hospital, or in the clinic setting, we're going to have a strong suspicion of if they have multiple sclerosis or not, and sometimes can even pretty much make the diagnosis just by seeing them. Of course, we do lots of imaging. It's really helpful for MS because it's really hard to see lesions of MS on a CAT scan. You pretty much have to use MRI. But those are to confirm what we already think, not to make a definitive diagnosis. So we should already know from the history and exam. So as we'll get into, you can't make a diagnosis purely on MRI. So that's important to keep in mind when you're seeing folks. Spinal taps, which I think most people are terrified of, we actually don't have to use them that much. It used to be very common, but maybe 1 in 10 or less than that, we might think about doing a spinal tap these days. And just a caveat with diagnosis, it's kind of a hard diagnosis to make. And there's a lot of opinion-based differences and variety depending on what provider on how you get there. And there was an interesting study where they looked at even large academic centers. The rates of misdiagnosis of MS was actually quite high. It was 20 to 40%. So it can be a tough diagnosis, and there are people going around with a diagnosis of MS that they don't have. So it makes it even more challenging for us. And there are people that are missed. Okay, so what are our subtypes? The most common by far is relapsing remitting. So we're going to start at the bottom of the graph and work our way up. And the graph shows a good way of kind of explaining how it presents. So on the bottom axis is time, and then the left column of the graph is going to be progression of disability. So as you can see on the bottom one, you see these spiky things, and then it levels off. So that's our typical relapse and remit. So we have a clinical event. Oh no. Can you guys see my like cursor? All right, cool. So we have a relapse, an acute neurologic attack, whether it be weakness, trouble walking, something like that. And we get worse and we have disability from it. And then it peaks, and then it usually gets better to a degree, but it may not fully get better. So oftentimes we're left with some type of disability from an attack. And if you have a lot of attacks, you can have a lot more disability build up. But the key with relapsing remitting, our most common MS by far, is that in between attacks, we're stable. We don't have any more other things, and we're not progressively getting worse. And as it says down here, 80 to 90% of all cases of multiple sclerosis are going to be relapsing remitting. So this is what we see most often by far. And then the next one up is called primary progressive. Thankfully, this is rare, 10 to 20% of cases, and it's just steady progression from the beginning. Not necessarily the relapses, although the top one here, you can have relapses mixed in certain types of it. But the main idea is progression that continues. And then we have a secondary progressive, which is, it's really sometimes hard to pick up on, is you have a relapsing remitting course, and then at some point, usually 15, 20 years or so into the disease, you can have a steady progression in between with or without relapsing episodes. And that's kind of the basic idea. Here's the types. There's a bit of a push now to go away from this, from kind of the MS community, and with the new criteria coming out, we may have less of this, as anybody can have some degree of progression underlying. So I think it makes it extra tough to kind of classify people. Okay, so what are relapses? So these are neurologic attacks. These are going to be at least 24 hours in length, and that's a big key for us and to help make the diagnosis. And they're usually going to last days to weeks. Symptoms come on, and then they kind of, I'll use my cursor here. They come on, they build up, they peak, and then they come back down. What we will not see is, okay, I had some blurred vision for like an hour and it went away. Well, that's probably not going to be attack. That could be from anything. So 24 hours is important to make sure we're getting the right type of episodes. And here's kind of the big 5 types of attacks. The technical terms are there, but the main idea is painful loss of vision in one eye. That's pretty stereotypical, optic neuritis. Then there's a process, intranuclear ophthalmoplegia. It's a lesion in the back of your brain. It causes your eyes to not move together. When your eyes don't move together, you see double. So people will have that as a very characteristic lesion of multiple sclerosis. And then there's ataxia, or a problem with your cerebellum. So usually you end up walking like you're drunk. And patients will actually say that. Hey, I had this go on. I don't know where it came from, but everybody at work thought I was drunk, and I told them I'm not. And it lasts for days to weeks, and then often goes away. And then kind of the subcortical lesions, these are things that look like strokes, but they're slower. So a stroke is going to hit you immediately. I was sitting at the dinner table, I was eating, and then I couldn't move my right side. Whereas anything with inflammation with MS is going to build up over probably a day or two till it reaches its peak point. And then a spinal cord attack, like transverse myelitis, weakness in usually the legs, sometimes the arms, bladder affected, and some sort of sensory change too. Okay, what about things that aren't attacks that we're also going to see a ton with our patients with MS? So these are more the symptoms, and symptoms aren't necessarily attacks. Fatigue, 90% or more patients with multiple sclerosis have fatigue. So it's not specific. Also, a whole bunch of people in the real world have fatigue. If you have young kids like I do, you have fatigue. Doesn't mean you have MS. Concentration troubles, also very non-specific. Pain, spasms and stiffness in the legs are more of kind of a downstream effect of an attack rather than necessarily the presenting symptom. Trouble with sleep, mood changes. MS population has much higher rates of anxiety, depression, and even bipolar disorder. So they are kind of part of the disease, but not necessarily an attack that helps you make a diagnosis. Headaches are also common, but headaches are common in general in the whole population. Seizures can happen, but usually not as an attack itself. So we just have to be careful what we use to classify someone with MS. Most of the diagnostic error comes from using these symptoms to make a diagnosis rather than a true attack. And that's why it gets complicated. All right, so this is very technical. We're just going to kind of hit the high points, but this is the diagnostic criteria of relapsing remitting MS. So the whole focus is on events or lesions separated by time and space. To have a true diagnosis, classically, before the 2017 criteria got changed, you had to have 2 events. Thankfully, now we can diagnose people faster after just 1, as long as they meet the criteria based on kind of all the other stuff we do. And we'll get into all the specifics of that. Okay, so time and space is the big key with multiple sclerosis. So DIS is dissemination in space. And where you can have lesions in your central nervous system is going to help determine what space. So spinal cord is an entire space. And then the other 3 are in the brain at just different segments. And we'll see some pictures and kind of point them out. But periventricular is the most common by far. And they're also the most subtle that people can have and not know it. And then time, if you have 2 events greater than 30 days apart, that counts as time. And then we can use imaging with MRI as long as we give them the contrast. If they have a lesion that takes up the contrast, then it's new. If one doesn't, then it's old. So that helps give us time. And then this is also where the spinal tap comes in if we end up doing that, because the presence of oligoclonal bands, that's the thing we look for with MS, that will give you time. So these are kind of the extra ways we test to get that answer. But again, if somebody has 2 clear episodes that are characteristic of MS, 2 attacks separated by 30 days, well, they probably got MS. And we'll confirm with MRI what we already know what the answer is. And the other key with every diagnostic criteria you'll run into in medicine, you have to not have a better explanation. And that's just kind of standard. Okay, then primary progressive is a little bit harder. These patients are going to be older when they're diagnosed, more 50s, even 60s. Whereas relapsing remitting, you're looking at your 20s, 30-year-olds, 40-year-olds. So different age group. Also, I think the sex difference starts to go away with primary progressive. Have to correct me if I'm wrong, Dr. Ward. I think it's pretty equal with males and females for primary progressive. So that's a little bit different population as well. But to make the diagnosis, you need a year of clear disability progression. And that's going to be, weak and stuff you're going to find on exam. Clearly weak in the legs, trouble walking. It's not going to be subjective stuff. It's going to be really obvious things. And then you get to imaging and you see lesions, and you have to have multiple lesions in the spinal cord or the spinal tap be positive to make the diagnosis. Because if you don't use the specific criteria, you can certainly overdiagnose primary progressive. All right, and then quickly about this one. So when people have an attack, but they don't have the rest of the criteria being met for true multiple sclerosis, they're not separated by time and space, then they get called this clinically isolated syndrome, which is you had some sort of demyelinating episode, an attack, and we don't know if you're going to have MS or not. And sometimes we treat them, sometimes we don't. And it kind of depends on other criteria. And then radiographically isolated syndrome, this is relatively new, and it's come about from doing MRIs on everybody for things even like headache. And then we find a bunch of lesions, and then we're like, what do we do with this? So that's kind of very much a new up in the air thing that's going on. And then bands, we kind of mentioned it already, but it's really helpful if you don't have time for the criteria. Presence of bands gives you time. And all it really is a marker, protein marker that tells you there's an inflammatory process going on in the central nervous system compared to the blood. So there's some focal thing happening in your brain spinal cord that's not going on in the blood. It is not specific to MS. It can be seen in acute infections and stuff too. So it's not a, there is no 100% accurate test for multiple sclerosis. But these are the ones we use together to try to help us. All right, let's do a case. So we got our typical 38-year-old female presents for evaluation. They have a history of migraine headaches, and they've had this new onset ataxic gait that's been happening for at least 2 days. And then last year, they had this episode that lasted for a few weeks of numbness, tingling sensation in their whole left arm. And then it went away. On exam, we don't find any sensory things or weakness, but we do have clear ataxia, trouble walking that shows up. So what do we think just based on this? On our history and exam, do we think they have MS or not?
Eric, I'm not going to answer because I'm not a doctor, but I just wanted to let you know that Sarah also has her hand raised, I think for a different reason, but we can tackle both of those. So go ahead, Sarah.
Sure.
Thank you. Appreciate that. Yes. Dr. Seacrest, on the slide before this with those bands, how are those identified in a patient that's happening or that those exist?
So this is what we get from the spinal tap. So we check this cerebral spinal fluid from that procedure, and we also check their blood, and then we kind of compare the protein thing in each one. So if there's a whole bunch of proteiny things in the spinal fluid that's not there in the blood, that tells us there's something going on.
Thank you. I appreciate that.
Sure. And what do you think? MS, not MS?
I could throw in some thoughts if nobody else has them. So in this case, I think it'd probably have one pretty clear event with ataxia, which has a really definite exam findings you can see. I think that left shoulder and arm pain can go either way because you can get some symptoms like that. Sometimes have a pinched nerve in your neck or other things. So it very well could have been an MS attack. I think there would be some question in my mind about could it have been something else? And it's a situation where sometimes it gets challenging. So I would probably need more information, but we'll see.
Beautifully said, Dr. Ward. And that is and the reason why this one's in here is to show that not everything, even neurologic episodes, are necessarily MS. Even if someone who has MS, it can be really tough, retrospectively trying to figure out what's what, because people get tingling stuff all the time, just from anything. So we want to make sure that we're really getting the right diagnosis. Now, if there was still a bunch of numbness, like if you tested them and they were weak in their arm, they were hyperreflexic in their arm, they had clear sensory loss, then I'd be a whole lot more suspicious about that episode. But when it leaves no trace on exam, it makes it a lot harder. And that's actually pretty common. Go ahead.
Yes, thank you. I was just going to add, not being a medical provider, if a friend or a family member told me these symptoms, I would definitely suggest that they see their medical provider, that these are alarming. As a medical provider, would this be a wait and see, or would this be a referral to the neurologist? Feel like these symptoms are significant enough to at least diagnose or rule out?
No, I mean, this is someone that, the gait, especially trouble walking, that's that bad. I mean, there's certainly possibilities for that, but most of them are pretty serious things that need sorted. Not many things will suddenly cause you to do that. Certainly the arm thing could be a pinch nerve, but who knows? And that's why it's really important to have people assessed, and to see what we're dealing with. So this may be someone, if they're not that bad, that they're still walking okay, not falling, that we could see them in the clinic and get imaging quickly and try to figure out what we're dealing with. Or if they're pretty bad, we might actually have them in the emergency room and in the hospital. And the idea with this is you don't necessarily have to be an MS doctor to at least see what the suspicious signs are. Because we will see people in our family, our friends, that are going to be worried about stuff. And if you work in healthcare at all, you're going to get questions. It doesn't matter what the training is. And this is kind of the idea. All right. So what we do with this case, well, we're going to get some imaging. And this is a great example of what multiple sclerosis lesions look like. So here's your brain, and this kind of black stuff. This is the fluid, what we call the ventricle, and thingies right next to the ventricle, we call them periventricular. So they're these kind of big, well circumscribed, usually spherical kind of things, white things. And then on this scan, this is actually with the contrast, and why it's so important to get it when we're doing an MS workup, is we see it's kind of bright right there. That was this guy, and this one is taking out some of that contrast. So that tells us it's new. So now we have new and old just from one scan. And given that story, and here's a lesion in the bottom of the brain, which is kind of your balance center. So this is probably contributing to their ataxia. In this case, we have an attack. Hard to say about that previous one, a little iffy, which is okay. But based on our imaging, we have different places. So there's some here, there's some down there, and we have the contrast, which tells us time. So the main idea, we can get them diagnosed really fast, as long as they present and we can see them and get our imaging in an expedited fashion. And the whole idea with MS treatment is earlier is better. If you wait until disability builds up, then you're fighting kind of an uphill battle by that point, and more likely to have significant problems with the treatment. We want to catch people early when they're doing pretty darn well if we can. And that's why we try to just expedite processes as best we can. All right, so this is kind of what we said. Clinical events, maybe 2, maybe just 1, but either way we get there. We do have time, we do have space, so this one counts. This is clinically definite, relapsing remitting MS, and we don't even need to do a spinal tap. So patients don't need to be worried about that. It's a very common thing where patients will avoid a workup because they're really worried about getting a spinal tap. And I hardly ever have to do it, which is great. But I don't like them either. All right, so next case, 53-year-old male, 1 year of worsening trouble walking, stiffness in the muscles, particularly the legs, having trouble with urination, not able to get all the pee out when he tries to go. And then he's also having cognitive deficits and memory trouble. And then on exam, we see things that correlate with that. The muscles are really stiff in the legs. He's spastic. He does have significant trouble walking, and his reflexes are greatly increased, which point toward a brain spinal cord thing. So this one's really concerning. So what do we think about this one? We could defer to Dr. Ward again.
So this is another one that's not going to clearly fit in the relapse part, because we don't have clear event where he all of a sudden developed trouble with his urination. This sounds to me like a more steady worsening process, but things noted on his exam. So increased tone means like stiffness in the muscles, spastic gait means again, like kind of a stiff gait, and then hyperreflexia is when someone's reflexes are increased, and all of those to really make us worry about a problem in the brain or spinal cord. So that's called upper motor neuron findings. So this is a person where I would probably be concerned about primary progressive MS, especially given his age and that he is a man, because primary progressive is more common in older people and men as compared to women. I mean, so women dominate the people who get relapsing MS, but you know, as Dr. Sechrist said, more equal in primary progressive MS.
Yeah, yeah, so I'd be worried about the same thing. But it's also possible this could be really bad tightness in the neck that's not even related to MS. But either way, this person needs some scans and needs assessed. This is pretty significant. In this case, we look at the neck. This is an MRI of your cervical spine, and he's there's fluid. The white stuff is still surrounding it, even though it's a little tight. Nothing's smashing the spinal cord though, so it wouldn't be causing those symptoms, but we do have some white plaque thingies in the spinal cord itself, and that's pretty typical of MS. We'll see some other scans. And they got stuff in their brain. Here's this white thing where the gray spinal cord is, the big white plaque in there. Those are all lesions in the spinal cord and the brain. So that's going to be pretty typical of MS.
In this case, with the his symptoms lasting about a year and kind of having some of those concerns about primary progressive, how long is a typical attack? I heard you say it's has to be over 24 hours, but is there an average length of time for a relapsing?
Yeah, thank you for that question. So our typical attacks with relapses are going to be weeks, usually lasting probably 2 to 3 weeks. Sometimes it's only a few days though. Depends on how severe, but got to be at least a day. In this case, with the primary progressive folks or just progressive in general, you just have that steady worse, worse, worse. And that's why it also takes people quite a while to get evaluated. I think the typical wait time from the lag between symptom onset to diagnosis is probably like 6 or 7 years. And a lot of times it's because symptoms, oh, I got stiffness in my legs, I'm having trouble walking. Oh, I'm over 50. I'm going to blame everything on that. And because it's so steady, it's really kind of easy to dismiss those symptoms, both as the patient and also as a provider, because you can blame it on arthritis or something. That's why it's one of the hardest ones to diagnose, is because that steady thing. People will get evaluated if they have big new symptoms that never happened before really fast. But that steady decline is much harder to pick up on. Yeah. All right, so this one, we'll worry about spinal primary progressive. We can probably do, I think we just got 2 more. All right, case 3, 30-year-old male. They were taking a hot shower and the left leg did not feel hot. Well, that's weird. Right leg felt normal. And then as the day went on, the next few days went on, they noticed their right knee would just give out on them, and they almost fell multiple times, but had no pain. And this kept getting worse for about 5 days. And then they had trouble with their right hand, could no longer make a fist, couldn't spread their fingers out, substantial weakness in their right hand. And that's where they sought evaluation. And on exam, clear loss of sensation on the left leg, and then weakness in that kind of right hip. And that's why it seemed like their knee was giving out, because they didn't have the strength to put weight on their knee. And then a lot of weakness in their right hand, and they had increased reflexes, which was very typical of something going on in your brain or spinal cord, essentially. And then we got imaging. We started with an MRI of the neck, and this is kind of what we see. So this is the spinal cord, this gray thing. Here's your bones on the back that you can feel. And you guys can see this white kind of vague patchy thing. So this is a demyelinating lesion of your spinal cord. And then when you take the contrast with the scan, then you see this well-defined lesion. And that's a very typical spinal cord lesion with multiple sclerosis. And then we need to know, do they actually have MS? So then we look at their brain, and their brain was fine. And then we did the spinal tap. We did see that they had elevated markers in their spinal fluid, but they didn't quite meet the full diagnosis. So only one event. We didn't see lesions anywhere else, so they're not separated in space. They do have time because of the spinal tap, but we still don't meet the full criteria. So this is someone that we would call clinically isolated syndrome. So that you had an attack, we don't know exactly what your future holds for you. Difficult to say. Some people we treat, some people we don't. And then the most important thing with these folks is we follow them and we get scans and we make sure we're not missing something. So follow up on this case, we did an MRI brain again at 6 months. It looked fine. And then we did another one at 12 months. And then we saw new lesions taking up the contrast. So that meant that we had separation in time and space. So now we have clinically definite relapsing remitting multiple sclerosis. But thankfully, patient fully recovered from the first thing and they're otherwise fine. So this is an ideal patient to treat. So hopefully you can keep them that way. And this is sometimes what we encounter, or at least low symptoms, low disability from the first attack. And oftentimes with good treatment, we can keep these people extremely good for a long time, which is where MS has advanced so much. So this one, now they meet the criteria. That's why we got to follow people. Oh, by the way, this is me. This is my case. So this was in 2018 when I was a resident in neurology training, and I got the spinal cord lesion. So that actually is my scan. And now I'm on medicine, and I'm good. Still haven't had another attack. All right. So then our last case, 48-year-old female, presents mainly with kind of cognitive complaints. Feel like they couldn't think, brain fog, and with more of an anxiety treatment approach that actually went away, and had an in-depth testing of their memory that was fine. And they never had anything else before. No attacks, nothing like that. We get MRI anyway as part of their workup for the memory complaint, and we see these lesions. And they actually look like MS lesions. And there's actually a lesion in the spinal cord too. Well, what now? Well, they never had an event before. They are separated in space and maybe even time if one of them takes up contrast. But as we said at the beginning, it's got to be a clinical diagnosis. So we can't diagnose people just by imaging. In this case, they never had a true episode. So these would be the radiographically isolated syndrome person. So their imaging looks like MS, but otherwise they don't have anything to suggest it. And these are people we follow too. All right, that's kind of the main point. And that's why we have to be a little bit careful throwing out a diagnosis if we don't have a clear attack. And something that we do see time to time with our referrals is that someone has kind of subjective complaints. They get an MRI and the radiology read says possible demyelination, because they kind of all say that. And then they're given a definitive diagnosis of MS before they see neurology, and we see them, and sometimes we have to take that diagnosis away, which can be pretty traumatic, challenging for folks. So it's really tough to make a diagnosis without having a neurology assessment. So kind of the summary of it, history and exam are what we need, most important. We're trying to figure out what's wrong. And then we use MRI to support what we're already thinking. Earlier you treat them, the better. You can keep people really, really good. And there's always kind of exceptions. That's why it really helps to have neurology. And we don't always need an LP, spinal tap. And the diagnostic criteria will change in the next few years and make it more complicated, but that's okay. That's why we're here, to figure out what to do. But the biggest points is, how do we get folks to neurology in an expedited fashion when there are concerns? And that's something that we're working on with our clinic. Since we have enough providers right now, and hopefully stay that way for a bit, that we can, if we get a referral from a regular doctor in ER, we can see them quick. But certainly a lot harder in other parts of the state.
And Dr. Seacrest, thank you for sharing your personal journey as well. You know, I've heard a lot of patients talk about the clinically isolated syndrome almost as though it's a misdiagnosis, and they later find out they have MS, or the other way around. But it sounds like the way you described it is that sometimes a stepping stone to the diagnosis as you wait to see what symptoms show up. And
Yep. Yeah, it's kind of, and the reason we can diagnose some people just by one attack, and if they have a bunch of imaging findings to support it, is because we followed those clinically isolated syndrome people for a long time and found that if you had a bunch of lesions, okay, you probably actually have MS. So it was actually following those folks that helped us diagnose other people much faster, and that continues to evolve. But it's not always a stepping stone to MS, and that's kind of a key part too. So not everybody will be or should be treated with a medicine to affect your immune system just after one attack.
thank you.
As long as we stay on top of it, keep seeing them, keep doing imaging in intervals, we can usually get a diagnosis, definitive diagnosis, even before they have another event.
Dr. Seacrest, I'm thinking you mentioned like around the state, trying to figure out the referral kind of process. I mean, what do you and Dr. Ward kind of think, like, you're a primary care doc that's seeing this person for 20 minutes, maybe, and they might have, these overall, all over the place kind of symptoms. Do you tell them to err on the side of caution and refer them, or like, what would you say as if you were in their shoes kind of aspect with some of this? That's a tough question. I know it's a tough one. I'm not going to hold you to it. Don't worry.
I mean, it's really tough. I mean, it's reasonable to get an MRI brain if you're at all worried about multiple sclerosis. And if it's totally clear, we can probably reassure that it's probably not MS, especially if you have a wide variety of complaints, especially those involving the face or talking or thinking. But still totally reasonable to get a neurology evaluation. I think one of the barriers to how quickly people can be seen, one, is there's not nearly enough of us. That's a big problem. But whatever, at least in our clinic, what the reason for referral is will kind of determine what neurologist you see and sort of if it's expedited or not. Because we have people that see everything, and we have people that see very specific things. So if the referral is for numbness, that's kind of the diagnosis used, but it's actually they had this acute attack of their entire arm was numb for 2 weeks. We're going to feel a lot differently about that. That might be an MS evaluation rather than a nerve evaluation. So that plays a role too. And I think that's sometimes why a diagnosis of MS is put down, so they can kind of get imaging and they can get kind of directed to the MS clinic, whether here or Marshall or wherever. But that ends up on the chart, and then people are like, oh, this must mean I have MS. So the way our system works causes us problems, which I'm sure you all know.
What are some of those? They're more commonly seen first symptoms or attacks that frontline primary care healthcare workers may see as more common indicators of MS?
Sure. And that's going to be we'll kind of back up here. We went over a lot of things. Let's kind of get to the beginning. It's going to be these guys. So these kind of 5 core ones, but basically seeing double for more than a day that's persistent. Painful vision loss in one eye more than a day. Even if it's less than a day, you probably at least should see an eye doctor, because that could be even something eye related. That substantial balance trouble lasting more than a day, that came on pretty quickly. Weakness, numbness on one side, maybe face droop, all those kind of symptoms, and then kind of various things would suggest spinal cord, but some of those similar above symptoms too.
Thank you.
Sure.
Any other questions or comments? Hearing none, I think we can, adjourn for the day a little bit earlier. I will let you guys know that our next one will be on April 3rd, and that's going to focus on the patient perspective. So we're going to hopefully have 1 or 2 patients on the session, and we'll try to do some more outreach to make sure we get a really good group for that one, since we are going to be asking actual patients to come in and share their insights and things. But we're excited to be able to offer that to the group. So please feel free to pass around the word. So we'll be in touch with more information on that. And you'll also get a recap email from this session where you'll get the recording. You'll also get access to the slides that Dr. Seacrest presented today as well. So please be on the lookout for that too. All right. Thank you again, Dr. Seacrest. Really appreciate it. Great talk, great cases. And we will see you all in April. All right. Take care.